Hi there, I'm Gabe Drapos, Chief of Staff at Pearl Health, and I have with me Dr. Vinod Mitta, advisor to Pearl, and our president, Ankit Patel. And we're going to talk a little bit today about some of the novel care measures the direct contracting program from CMS has introduced. Specifically, I want to talk to both of you about the value of pairing capitation with risk exposure and quality measures, and how that maybe differs from other value-based care programs that CMMI has tried in the past efforts of capitation in especially the HMO context in the 90s, where some of that floundered. So would just love to kick that off with your thoughts.
I think what happened in the 90s is you put doctors on capitation, and for lack of a better way of describing it, once you got your fixed PM, you're just basically hitting the golf course every day at 3 p.m. And, once that world happens, there wasn't a lot of data, there wasn't an infrastructure to be able to manage and keep doctors accountable now that they're getting a fixed salary. And so insurers kind of thought that the whole thing ended up being a mess, where we're just kind of giving fixed money and guaranteed payments to doctors, but not really getting anything in return. You fast forward to like the 2010s, and we've all been talking about value-based care. And, the consistent issue has always seemed to be this approach where I have to do something today, and then I will get rewarded and paid for it 18 months down the road. And then, you're sort of sit there asking, well, how do I make my payroll today? How do I pay for my care managers? How do I pay the nurses? In order to do value-based care, there has to be some recognition that there is capital cost up front, and there needs to be some financial stability so that doctors can now focus their time on the risk part of their business rather than having to run the two at the same time.
But previous efforts weren't as centered on the physician and giving autonomy and financial independence to the physician to practice. ACOs, HMOs were ultimately larger groups, administratively driven, and it's hard to get that culture of risk-taking when it's offered at the administrative level down to change the behaviors and the mindset for an individual practicing physician. Hopefully DCE changes that a little bit. It more directly applies to the individual physician. It's a program that makes sense. When you change your practice patterns, it very clearly affects your financial outcomes in a very direct way, in a very real-time way that doesn't have to factor into the business cycle for the hospital or the ACO or the HMO, whatever that organization is. So I'm curious if maybe DC lets physicians appreciate capitation in a different way.
Those of you watching at home are intrigued by conversations like this, visit pearlhealth.com, where we have more information and a new jobs page.